Again, thank you very much for the kind hospitality and the reception we had since we arrived in this nice city. And I would like to thank the director of the university, my friend Ahmad, and other colleagues for giving us the opportunity to be here and to talk to you about mycetoma. I think by now you know me, so there is no need for the introduction. I'm going to talk about mycetoma. I'm going to talk about the challenges we are facing with dealing with mycetoma patients. And then I'm going to discuss with you the opportunities we have to improve the quality of the life of mycetoma patients globally. First, ladies and gentlemen, I would like to declare there is no conflict of interest in this presentation. An apology for showing you some of the photos, which are not very nice, especially for non-medical colleagues. All photos were taken after informed consent from the patients or from the guardians. The main objective of this presentation is to share with you experience on mycetoma as a neglected medical and health, as well as a socio-economic problem. The other important objective, it is to identify areas of opportunities and challenges we are facing dealing with mycetoma patients. For those who may not be able to stay to the end of this presentation, I am going to conclude this presentation by saying mycetoma, it is one of the badly neglected tropical diseases. It is a serious problem. It is a disease that has impact on patients, families, communities, as well as the health system in general, because it is non-glorious disease. Other important conclusion, I'm going to conclude my presentation by saying that mycetoma diagnosis is lacking behind. We have many difficulties in establishing the proper diagnosis of mycetoma. Currently, the treatment of mycetoma in many centers is suboptimal with many complications. And currently, there is no control or preventive program for mycetoma patients globally. And our job is to correct these difficulties, as it is one of the non-glorious diseases. Lastly, I'm going to conclude by saying mycetoma is a scar on the human conscience. And our job is to heal it, because it is one of the non-glorious diseases. A lot of people, they don't work with patients with mycetoma. They have a lot of problems and complications. The presentation I'm going to give based on our experience at the Mycetoma Center, which was established in 1991. We treated more than 10,000 patients with confirmed mycetoma at the center. I would like to take you through a virtual visit to the center.
Research, excellent education, teaching and training in the various aspects of mycetoma, and exceptional community development activities. Mycetoma is a flesh-eating disease endemic in tropical and subtropical regions throughout the world. Many people in Sudan still seek treatment for mycetoma from traditional healers and fakir faith healers. This is ineffectual and results in late presentation to qualified doctors. There is a massive knowledge gap in the epidemiology, pathogenesis and management of mycetoma, and that has severely affected patient management and proper planning for mycetoma prevention and control. The Mycetoma Research Centre is a World Health Organization collaborative centre, recognised globally as a world leader and an authoritative advisor in mycetoma management and research. It is a one-of-a-kind worldwide as a specialised centre to deal with mycetoma patients. The Centre is dedicated to the continuous discovery and development of scientific knowledge and clinical skills, and to apply that to the care of mycetoma patients. The MRC vision is to continue to be the world leader in mycetoma management and research. The MRC mission is to eradicate mycetoma, which is a life-mutilating disease, through the advancement and innovations of patient care, scientific research, education and community advocacy. The Mycetoma Research Centre objectives are to provide state-of-the-art, multidisciplinary, individualised care to patients combining medical, surgical, nursing and social expertise, to conduct outstanding scientific research, to offer an energetic and effective program of teaching and education, to deliver effective community development activities, to establish national and global databases on mycetoma, and to establish national and international partnerships to carry out these objectives. The MRC has 4 committees to plan, monitor and evaluate its activities: a clinic committee, a research committee, a committee for education and continuing professional development, and a committee for community development. The MRC is staffed with experienced professionals with medical, health and scientific backgrounds.
Okay. This is a virtual visit to the center, and you will find this video at the Mycetoma Research Center website. So I don't want to waste your time with this. It is there available. Ladies and gentlemen, mycetoma, as I mentioned, it is a neglected tropical disease. In fact, mycetoma, it is a unique neglected tropical disease. And I will show you why we call it a unique neglected tropical disease. Mycetoma, you can see, can be a very devastating medical problem. A patient with intracranial mycetoma, a space-occupying lesion with a lot of morbidity and mortality can occur. You can see how shattering the mycetoma is. You can see how massive the lesion at the affected site at this site. And again, it is a very mutilating problem. This young chap has a bacterial type of mycetoma. It is a very benign condition that can be treated by medical care, but still he had an amputation. And you can see the misery of this patient, young patient with amputation of the hand, and the socio-economic stigma and problems after that. You can see how disfiguring the problem is. You can compare the normal leg with the abnormal leg on the other side. It is a disabling problem. Amputation of a lady, she always has to be supported by one member of the family at this site. Right. Mycetoma has 2 types of mycetoma. We have the fungal type called an eomycetoma, and this is caused by a good number of causative organisms. Currently, we have more than 70 microorganisms capable for producing mycetoma infection. These are the common organisms causing the fungal type, the eomycetoma. For the bacterial type, it's called an actinomycetoma. These are the commonest type of microorganism that can cause mycetoma, actinomycetoma infection in this patient. Recently, at the Mycetoma Center, we managed to identify more causative organisms causing mycetoma for the first time. And still you have more cases to be identified. Again, you can see all these are new cases of mycetoma identified for the first time at the Mycetoma Center, and you can see the different types of organisms. So again, with the new techniques, the MRI, the PCR, the sequencing, we can every time find a new type of organism causing mycetoma infection. In Somalia, Streptomyces somaliensis is the commonest type of infection. But I am sure with the new sequencing machines, the PCR apparatus, we can identify more organisms in this country, and that can be an asset to the international decision at this site. Interesting enough, the fungal type, the EU Mycetoma, and the bacterial type, the actinomycetoma, although they have different causative organisms, but they have the same clinical presentation. And we are not sure why this diverse of organisms can produce a simple presentation in such cases. So this is a question that needs to be answered in the future. Again, the epidemiology of mycetoma, till now we are not sure about the global, worldwide incidence and prevalence of mycetoma because it is one of the badly neglected tropical diseases. However, it is reported between 15 south and 30 north, and that is called the Mycetoma belt. The Mycetoma belt includes Sudan, Somalia, Mauritania, South America, Mexico, India, and other countries. It was reported in 102 countries globally, the mycetoma infection. And this is the last map produced by the MRC Mycetoma Center as well as the WHO in Geneva. Again, as I mentioned, the incidence, the prevalence varies from part to part depending on the activity of the researchers at that time. So we cannot generate a full blown idea about the incidence and the prevalence around the globe. Still, we don't know how the infection is taking place. It is believed that the organism inside the grains, which are the encapsulated form of the organisms, are shed in the soil, in the environment, and there are some changes taking place in the nature of this organism in the soil, and then probably there is a facilitating structure or an object or organism that can facilitate the inoculation of the infection in the subcutaneous tissue of the affected patient. Still, we are not sure whether there is an intermediate host or not for mycetoma, and if it is present, what is it? And we are not sure why not all people at endemic area can develop the mycetoma. It may be immunogenic, it may be genetic, it may be environmental factors that can cause the infection in certain people in certain areas. Probably inoculation is taking place by a sharp object, a cut in the skin, implanting the organism in the subcutaneous tissue. The evidence of that, we found in some patients a thorn at the mycetoma granuloma during surgery, and in one of the thorns we found the microorganism. It may be accidental, or it may be a vehicle that can take the organism to the subcutaneous tissue. So this is an area needs more studies and more evaluation. Again, resistance and susceptibility. It can be due to environmental factors, as I mentioned, or it may be genetic factor, or it may be the immune system of the affected patient is abnormal, and that may be the cause of the infection in this patient. This is a typical village where mycetoma is endemic. The people are in direct contact with the animals, with the animal dung, with the dirt, and with the sharp objects. We did many studies on the environmental factors in one of the affected villages in eastern Sinnar called Wadanimer. And we compare that with another village 1 mile away with no mycetoma. We look into the soil, into the temperature, the humidity, the wind, the sun, and we did not find a substantial evidence that the environmental factor may be a very important. But we need to have more studies, more ideas about the environment, especially now we're talking about the climate changes for the diseases. Right, genetics, we notice that in many patients there is a strong family history of mycetoma. This is a group of patients, young patients from the same village and from the same family at this site. So hence, there may be a genetical factors that may cause the mycetoma infection at this site. Once again, they have to look into the immune system of this patient. And again, there was no shouting evidence that this patient having an immunocompromised conditions at this. None of our patients had HIV, and most of them are healthy young individuals. Mycetoma typically enjoys all the neglected tropical disease characteristics. It affects the poorest of the poor in poor remote communities. Farmers, workers, dealing with the soil, dealing with thorn and sharp objects are more prone to develop infection. Typical mycetoma patient, we have a very massive socio-economic impact on the patient, the family, the community, and the health system at the affected site. The stigma is a very serious consequences of the mycetoma. And most of them, they drop education, they lose their job, and they have many social problems at this site. As I mentioned, most of the patients are farmers, workers, dealing with the soil. In endemic areas, other people with other occupations are affected. We have doctors, we have teachers, and other occupations. Children and students are affected in about 30% of our cities. And you can imagine the problem of these patients. They lose education, they cannot work in the future, they can go into a cycle of poverty and stigma and diseases. This is a young lady, 15 years old, has a mycetoma of the head and neck, and you can see how miserable the presentation of a lady like this. Most of them are really young chaps. Almost 30% are children. We notice that males are affected more than the females. We don't know because it was believed that males are actively involved in outdoor activities. But in endemic areas, females are involved in these outdoor activities as well. So that may not be the case. When we do a surveys in the villages, the incidence it is almost equal. This is one of the patients, the poor quality of the life of these patients coming to the car like this, with a cart like this. We notice during pregnancy, the disease becomes worse, more sinuses, more discharge, and more activity. And probably during that time, the immune system is low to accept the fetus and the newcomer. The clinical presentation of mycetoma, it is very simple. It is a subcutaneous mass, painless in nature, gradually increasing in size. And then you can see another nodule might develop here in this patient. Right. It increased gradually in size. It is painless in nature. and it can reach a size like this. These people are of low socioeconomic status. They are the poorest of the poor in poor remote countries. They have other problems apart of the painless mass in the foot or the other side. Eventually, the patient may develop multiple sinuses, and the sinuses discharge grains. And the grains can be black, as you can see here in this slide, or it can be white, yellow, and red. And the grain is an important feature for the diagnosis of mycetoma patient. It can spread locally along the facial planes, but interesting enough, we notice that the tendon and the nerve are rarely affected in mycetoma patients, and nobody knows why. It can affect and destroy the bone, but cannot affect the tendon and the nerve. And again, this is a Nobel Prize question. If you know the reason, that may be used for the treatment of mycetoma patients. It can spread by the lymphatics to the regional lymph node, where a new satellite can develop at that site. And here you can see, this is a patient with a mycetoma of the foot, is spreading along the lymphatics to the regional lymph node, causing a new satellite in the inguinal region at this site. In some patients, there may be a genuine lymphatic spread, and this is a lymph node, removed surgical, is studied with the black grains. That is real, a lymphatic spread to the regional lymph node, and you can see here. Apology for the quality of the slide because of the system here, not compatible. A spread can take place by the blood as well. And this is the evidence. This is an intact blood vessel. Inside the blood vessel, there is an actinomadura pelletieri grain, which you can see around that there is the red. This is the grain, and this is the red blood cells at this site. So that may indicate that it is a blood spread disease as well. Right. Where can we find mycetoma in the body? Any part can be affected, but about 80% are seen in the leg, in the foot, and the hand. And the hand, the right hand more affected, probably it is occupational, I don't know the cause, but you can see in the groin, primary infection or secondary. This is a poor patient, has a mycetoma of the hand, had an amputation, he had a below elbow amputation, had the spread, it moved to the lymph nodes in the axilla, another sinus is there, and affected the breast of this patient. So the breast, the axilla can be affected in this patient. The eye can be affected, and you can see in this patient, the eye is badly affected and infected with secondary bacterial infection and the mycetoma itself. Other side, the gluteal region, the perineum, the scrotum, the vulva in a female, all these were reported to be a site for mycetoma infection. You can have a very complicated case like this. Mycetoma of the hand, of the foot, is spreading to the side, to the inguinal region, and to the hand. And here is a management dilemma for this patient. This articulation for a patient like this, with amputation of the hand, and you can see the misery and the quality of the life of this patient after this amputation. Sometimes the infection can take place by two organisms, bacterial and fungal type. And this is a treatment challenge, because what shall we do for this patient? Combine both antifungal and antibacterial with all their side effect and toxicity. The outcome of mycetoma depends on many reasons, many factors. the type of infection. The fungal is more aggressive, bad prognosis. The site of mycetoma, extraepithelial in the head and neck, more aggressive, more fatal. The duration and the immune status of the patient affected at this site. The patient, they live with misery for life with this patient, either with the treatment or with the treatment complications. Diagnosis of mycetoma, it can be clinically, but this is deceiving because the grains may not be seen and many organisms may have the same color of the grains at this site. We need to identify the organism to the level of the species. And here we have cytology, histology, culture, and the PCR identification for these patients. We need to know the extension of the mycetoma in the body. And here we have a lot of imaging techniques that can be used for the diagnosis of mycetoma. It can be a plain X-ray, an ultrasound examination, an MRI, and the scan, CT scan for this. Invasive and extensive and expensive are the shortcomings of the available mycetoma diagnostic tool. We need to do a lot of invasive procedures. Sometimes we need to go for surgical excision to get tissues for histology and for culture and for PCR identification. And this is associated with a recurrence. Remember the shortcoming of the diagnostic tools available: low sensitivity and low specificity. All right. Other important shortcoming of the mycetoma diagnosis, you need to have a combination of tests. This is head and neck, this is a cranial mycetoma. We need to have an MRI and CT to see the extent of the problem. We need to explore, take a biopsy for culture, for PCR, and for histological diagnosis. So always you need to have a combination of diagnostic. The most important serious problem with mycetoma diagnosis, there is no point of care test for mycetoma. There is no single test can use in the field, in the village, to confirm the diagnosis of mycetoma patients. So this is an important shortcoming of the available diagnostic tools for mycetoma infection. These patients present late and they have a poor management because there is no point of care test at the village level. They have low socioeconomic status and they present late with very advanced disease and problems. Many of these patients try to use the local native treatment available at the level of the village first, and that an important cause for delay to present for a medical care and support. In mycetoma endemic areas, there are a lot of problems. This is a rainy season in one of the endemic areas where you can see how bad the roads are. And in many parts of Africa, people come to the hospital with this. And you can see how massive the cavity in the bone, and you can see how mutilating the excision of the affected tissue. You can see through the area at this site. But the good thing, some of the patients, they respond nicely and they heal nicely at this site. This is compared with the preoperative photo at this site. Right. This is a patient with mycetoma. For years, I just have this mycetoma of the back, of the loin, the chest wall. He had treatment for 3 years, and then he had wide local excision. And this is the patient at the post-operative period. A different person at this site. So you need to have patience with the patient. You need to have more encouragement for the patient. Talk to them, encourage them to come for follow-up and to see what shall we do for them. Right. This is a patient with massive mycetoma of the gluteal region, the perineum, the scrotum, the root of the penis. He stayed in the ward with us for 3 years, daily dressing. He had more than 40 surgical excision and a colostomy, and eventually had a good healing at this time. He was discharged in a good shape, but he disappeared from follow-up, and he came back with a massive recurrence. After all this surgery, admission, treatment, and this. In developing countries like Somalia, like Sudan, amputation is a social stigma. Many people, they don't come because they know if they can come, they will end in amputation. So when they come late with very advanced disease. This is a young chap. He had a mycetoma of the foot. He insisted to have an amputation, which is not very common feature of young people like this. But because he was in misery, in great pain. This is one of the sad stories of mycetoma. This was a young chap, 21-year student, a university student, have a massive mycetoma of the knee joint. Yet this is an MRI, showed a massive involvement of the subcutaneous tissue. We did a very good curettage. We removed everything from this side. Then he developed a spread in the groin. Again, we did a massive excision of the groin, lymph nodes, and everything. He was very happy about that. One day he came coughing, and the X-ray showed massive mottling feature like this. And then he started to cough the grains. And this is the CT scan of the patient, just like a malignant disease. And he died from septicemia and from the affected lungs and disease at this side. This is another chap, a teacher from Central Sudan. He had a mycetoma of the upper side, multiple surgery. Eventually, he had a massive disarticulation of the whole lower limb. Then he developed massive recurrence. It spread into the intra-abdominal cavity, to the internal organs. And you can see this is one leg, and this is the massive lesion in the subcutaneous tissue. And this is the lesion here, you can see, extending to the bladder and the soft tissue at this side. And again, this patient had a massive disease, this intra-abdominal affection, the MRI, CT scan, showing that. And then he started to cough the grains, again, to the chest. And the cough produced, we isolated the candida and the Mycetoma mycetomas infection at this site. CT scan showed a massive pleural effusion. And this patient died from septicemia and from the chest infection. So what are the challenges we are facing this patient? Treatment, not very effective. Diagnostic test, not very efficient. And no prevention plan for this patient. And these are the urgent priority you have. The other challenge is that we need a good diagnostic test for mycetoma patients. And we are working now with many international bodies in Japan, in Mexico, in the Netherlands, in the UK, trying to find a diagnostic test which can be easily done at the level of the village. Again, there is no prevention plan because still we don't know how the infection is taking place, and we don't know many of the epidemiological characteristics of the infection. Ladies and gentlemen, there's good news. And the good news now, WHO is started to be interested in mycetoma. And it is included as one of the neglected tropical disease number 18. And again, it is recognized in many of the activities by WHO. And that is why you have to grip this opportunity and to work with WHO to improve the quality of the life of mycetoma patients. We have a lot of friends and associations supporting the mycetoma patients, and we need to work together at the level of the village and the community to improve the quality of the patient's care. Again, the good news, just recently, we finished the first ever double-blind clinical trial for a new drug for mycetoma called vosoruconazole. Nowadays, we are giving the patient itraconazole 4 tablets per day, and the new drug is given once per week. You can compare 1 tablet per week with 4 tablets per day, and the compliance and the difficulties the patient are having with these drugs nowadays. This is our lab, and this is some of our chaps in the lab working there. We hope you can see you there working with us at the Center for Mycetoma Patient Care and this. And this is a video on the lab at the Mycetoma Center. And thank you very much for your kind attention. And this is my contact, the email, the website, and the Mycetoma Research Center website. Thank you.